Okay, Dorala, should I start or wait more?
We can start now. Welcome everybody.
Okay.
I will take care of the audience.
Okay, so welcome everybody about this session. Now, this session selected by the request of some people. So the topic is not very prolonged, but I will try to add some clinical tips to it. And the high frequency ventilation are of three types: the high frequency oscillation, the high frequency jet, and high frequency flow interrupter, as most of the Middle East uses high frequency oscillation. So today the main talk will be about high frequency oscillation. So how we should ventilate a baby? Well, we need a specific strategy for each pathophysiology. And we have to pick a ventilator that actually meet that pathophysiology. So when you buy or order or deal with ventilator, you have to know whether that ventilator can deal with that pathology or not. And therefore, you always need to select, for example, in neonatology, a ventilator or neonatology designated ventilators. Now, the ventilator strategy should change with the change of pathophysiology. So RDS become PDA, PDA become infection, infection become chronic lung disease become, resolved, and so on. You need always to change when you ventilate a baby. And the time of extubation should be started at the time of intubation. Now, what is the goals? What are the goals that when we use assisted ventilation? Well, the goal is to inflate all the lung. As you know, we have more than one zone. And we have the inflation zone, we have the matching zone, and we have the perfusion zone. Usually the ventilation zone is more inflated with air, and it's the uppermost. So if you are standing, it's upper part of the lung. If you are lying, it's the anterior part of your chest. And the perfusion zone is usually the zone that is most posterior, most dependent. And in between, there is the matching zone. So our aim is to achieve a uniform lung inflation, but most of the time that is difficult. The second aim is to prevent the over ventilation area or under the perfusion area. So we like to always go to the matching zone. We need to give as much as low oxygen as possible, and we need to extubate as early as possible. There are points during ventilation that is very important. The first important point is the critical opening pressure. The second is the maximum pressure before we reach hyperinflation. The third one is the critical closing pressure. So remember these when you ventilate: critical opening pressure, maximum pressure, and critical closing pressure. The least traumatic, the least damaging ventilation is in the matching zone, in the matching portion of the pressure volume curve. So here we have the pressure, and here we have the volume, and this is the PEEP. So when we start ventilate, the ventilation will give the inspiration to the patient. And you can see the ventilator started from the PEEP. And the pressure is increasing, but with minimum volume, until we reach a point where a minimum change in pressure gives you maximum change in volume. And that's what we call it critical opening pressure. The time or the difference between the start of PIP and the critical opening pressure should not by any means become double the PEEP. If you become double the PEEP, then probably you have a non-compliant lung, or you are using low PEEP, or you are losing the PEEP. And then you reach to a point where increasing pressure will not give you volume. And that's what we call it the critical maximum pressure. After that, we don't want the ventilator to do. So anything above that is not important. So once you reach this point, and if you have higher PIP, you need to decrease it. Then exhalation start. And you can see the pressure stop, reduce, 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 until you reach a point where a little movement in the pressure, a little reduction in the pressure, give you lots of collapse in the alveoli. And that's what we call it critical closing pressure. So after the critical maximum pressure, we don't like it because of over-distension. And after the critical closing pressure, we don't like it because of atelectasis. So, over-distension, atelectasis. And that's what we call it unsafe zone. That's what we call it injury zone. Injury due to derecruitment, and injury due to overventilation. Where we want to ventilate the baby in here, in what we call it safe window, safe zone. Now in adult, there is a huge difference between the functional residual capacity and tidal volume. So the functional residual capacity of an adult about 25 centimeter or mil per kg. And the tidal volume is about 10 to 12. And to cause injury, you need to reach up to between 40 to 80 mil per kg. So it's a very high margin before we can cause lung injury. In term baby, the margin of making damage is even smaller, while in a preterm baby is even tiny. So a little bit change in tidal volume can cause lung injury. So this you need to keep in mind. Now we've remembered the over distension injury and under inflation injury and the safe zone. Now when the ventilator gives the ventilation in conventional ventilation, the ventilator will give the PIP up and down, above and below the safe zone, which is this color, the light color. There is no way that we can avoid the swinging of the pressure between hyper and hypoinflation, where we want the ventilation to be in safe zone. So you can see the ventilator gives ventilation here. When we use high frequency, we can achieve same, but within the safe zone. So the fluctuation or swinging of the pressure avoid the red hyper and hypoinflation where we cause injury on either side. So the high frequency aim is to limit the damage by eliminating the pressure and the volume swinging. We also can cause decoupling, so we can control the oxygenation and ventilation by different parameters. So we can control the oxygenation by changing the MAP or versus PEEP, and also we can change the frequency and the difference between the MAP and amplitude that give us the delta P. In this, we can control the CO2. Now, we have mainly two types of high frequency, the oscillator and the jet. Now, you need to know that there will be attenuation of the pressure once the pressure moves from up till down. So you can see that in conventional, once you move down, the damping or the attenuation of the pressure once you move distal is very small, and almost the pressure applied to the proximal airways is almost same of the distal airways, while in high frequency it is attenuated until you reach a minimum change at the alveoli to prevent the damage. So in conventional mechanical ventilation, the mean airway pressure is fixed and the maximum amplitude is fixed too. In high frequency, only the mean airway pressure are fixed while amplitude are not. In jet, both are attenuated. So you can see in high frequency, the mean airway pressure, which is the result of PEEP, PIP, inspiratory time and others, are fixed, never change. While in high frequency, the mean is the same, but the amplitude will be attenuated once you move further. In high frequency jet, both are attenuated. The amplitude and the mean airway pressure once you go distal. So when we use high frequency ventilation in a preterm baby, when our PEEP in conventional exceed 30 centimeter water, when our tidal volume exceed 6 ml per kg, when we need a rate more than 60 to wash CO2, when we have air leaks, whether it's a PIE or pneumomediastinum or pneumothorax or emphysematous changes or plebs, whatever. And sometimes you can start electively in very extreme preterm baby. And sometimes when your ventilator fails, the conventional ventilator fails, so you do it as a rescue. If you have severe pulmonary hypertension that needs inhaled nitric oxide, mostly you will use the high frequency ventilation. What is the difference between high frequency jet and oscillator? Now, the oscillator is not limited. We can use it in a big babies, while the jet is limited to very small babies. In oscillator, the mean airway pressure are constant. The relation between the inhalation and exhalation are both active, while in the jet, the inspiratory time are very short. And we have a variable I-E ratio because the E is passive. So the ventilator is only push in and the recoil of the chest make it out. The oscillator are very ideal for homogeneous lung disease, while the jet are ideal for non-homogeneous because of the attenuation. The oscillator is ideal for use with inhaled nitric oxide. The problem with oscillator is cause airway trapping. And the reason because the out is active, and when the ventilator sucks the air out, the first part to collapse is the upper airway and not allowing the distal airway to clear. While in jet, because the out is passive, there will be no air trapping and air leak, and it's ideal for air leak diseases. So if we look at the CMV, and we can look at that, we have a PEEP, and we have the PIP, and we have the main airway pressure. In the ventilator, the mean airway pressure is a little bit above the PEEP by 1 to 2 centimeters. And we minimize the PEEP and also we minimize the amplitude. And therefore we avoid the hyper and hypoinflation. The jet, because it's only the passive side, only on one side, then we can use a lower map and a lower tidal volume than the high frequency. High frequency is about 1 to 2 centimeters above the mean airway pressure of high frequency jet. So how high frequency works? We have a CPAP system to create the pressure, and we have a piston attached to a membrane to displace the gas. We have active exhalation, and the high frequency uses a tidal volume equal to dead space, which is 1 to 3 ml per kg. We can use a rate of 180 to 900, each one frequency equal to 60 respiratory rate. So when you use a frequency of 1, we are using actually 60 respiratory rate. And we use a frequency of 2, we are using 120 and so on. And when using 180, we are using frequency of 3 and so on. We use way low PIP in comparison to the level of the map that we can achieve on conventional. And we can separate the control of oxygenation and ventilation, or control of oxygen and CO2. How we do decoupling? Well, we can control oxygen by controlling the mean airway pressure and the FiO2. But we can control the ventilation by changing the amplitude to get the delta wave, which is the difference between the MAB and the amplitude. And also we can change the hertz, the frequency. The primary control of oxygen in high frequency oscillator is by MAB and also by FiO2. The mean airway pressure is a constant pressure in high frequency, and the frequency moved around it in a positive and in a negative, in and out. And therefore our alveoli are always open. Since the mean airway pressure is constant, it reduces the lung injury because we are not causing hyper and hypoinflation with each breath. So the mean airway pressure and the oxygenation are actually constant, and the alveoli opening. So how we do oxygenation? We try to open the lung volume as much as we can, unless we have air leak. So what is the benefit? We provide homogeneous gas distribution. We avoid the hyper and hypoinflation. We reduce regional atelectasis because we don't go below reaching to the PEEP. We achieve maximum ventilation perfusion match. And not education, causing reduction, not education, this is spelling error, of intrapulmonary shunting. And in high frequency, we are able to use a lower FiO2. Now, how we initiate high frequency? So what we do, we observe the mean airway pressure on conventional. Then we select a mean airway pressure in high frequency to be 1 to 2 centimeters above the mean airway pressure on conventional. Then we increase the mean airway pressure by 1 centimeter to achieve optimal lung volume. Optimal lung volume, we determine it by increased saturation and dropping FiO2. And also we can assess it by chest X-ray or even lung ultrasound. And how we control ventilation? There is a piston or pump that force the delta change between the positive and negative, between in and out, on a speed achieved by the frequency. In ventilation, in high frequency ventilation, the alveolar ventilation, the minute ventilation, equal the frequency times the tidal volume in conventional mechanical ventilation. While in the alveolar ventilation and high frequency have same definition, but it affects less by frequency. It affects mainly by the tidal volume, while the tidal volume or the minute ventilation in conventional affect both by rate and the tidal volume. So how we increase the stroke volume in high frequency? First, we can increase the amplitude. So once this is the map, once we increase the amplitude, we get more tidal volume. The second is we decrease the frequency. So the less the frequency, the more wider the waves will be, and the more tidal volume. So to increase tidal volume, we need to increase the amplitude to get better delta wave, which is the difference between amplitude and the map on either side. Or we drop the frequency to give more room for the pulse, for the waves to get bigger and achieve the tidal volume. So we started the conventional. We have a conventional mean airway pressure, let's say 12. Then we will put the mean airway pressure of the high frequency at 13 or 14, which is 1 to 2 centimeters above the mean airway pressure in the conventional. And then we select the frequency. Now the smaller the baby, the higher the frequency should be. The more homogeneous the disease, the higher the frequency should be. The bigger the baby, the more term the baby, the lower the frequency should be. the more non-homogeneous the disease, the lower the frequency should be. To improve ventilation, we need to increase amplitude. If we increase amplitude and we cannot achieve CO2 elimination, we have to decrease the frequency. Once we reach amplitude, to triple the size of map, you need to drop the frequency by 1. So how we achieve a tidal volume in high frequency? We maintain the same tidal volume because there is no change during exhalation and inhalation between the baby and the machine. It is very fastly moving and there will be no change. And therefore, we ventilate in a safe zone and we do not cause lung injury. And because no change, the CO2 is supposed to not fluctuate in CO2. So how we do that? Check the average map on conventional mechanical ventilation. Add 1 to 2 centimeters to the map of high frequency. Make the amplitude double the map. So let's say the mean airway pressure on conventional ventilation is 11. Make the mean airway pressure on high frequency 13 and make the amplitude 26. So the map in high frequency above the map of conventional but when we say high frequency, we're talking about oscillator, not jet, because jet is different. So make the map of the oscillator 1 to 2 centimeters above the average map on conventional. The average map, get it from as a measured value in conventional. And then we make the amplitude double the map. And in a big baby, in a small baby, we start very high frequency. In a term, we use less. In a homogeneous lung disease, we use higher frequency. And in non-homogeneous, we use lower frequency. So let's say this is a premature baby and you select a frequency of 11. Then hit start on the ventilator. Look at the chest rise. If you do not see chest rise, increase amplitude by 2 centimeters at a time until you see a chest rise. Once you see the chest is become rising and waggling, then stop rising the amplitude. If you need amplitude more than triple the map to achieve chest movement, then drop your frequency by 1. Look at your saturation. If saturation is low, increase your map by 1 centimeter at a time. When you increase the map by 1 centimeter, you need to increase the amplitude by 1 centimeter to keep same delta wave, which is the difference between the amplitude and the map. You keep increasing your map until you can drop the FiO2 to lower than 40%. Then you need to select your IE ratio. We usually start by 1 to 1, and then later on I will explain how this will be selected and why. Then you can do X-ray or gas or lung ultrasound and a gas. If your CO2 is high for the gestational and postnatal age and your pH is less than 7.2, then you can increase your amplitude. But remember that the amplitude should not be triple the size of map. If it does, then you need to drop your frequency. If you can achieve CO2 more than, then you need to stop. Then you do an X-ray. if your X-ray showed hyperinflation, and we'll talk about how we do that, then you need to try to decrease your amplitude. If your CO2 high, you don't need to change the map. But if your CO2 is normal, you decrease amplitude by 1, then you need to decrease by 2, or 1, then you need to decrease the map by 1. If your CO2 is normal, wean your amplitude down until it becomes less than double the map. If your FI2 is 21%, wean your map by 1% at a time. But when you mean map and your CO2 is normal, when you wean your map, you need to wean your amplitude too to maintain same delta wave. If your amplitude less than double the map and your CO2 is still low, then you might need to increase your frequency. If your frequency more than 12, your map less than 11 with amplitude less than double map, you might need to consider back to conventional ventilation. What is the problem when you ventilate a baby on a high frequency? First, the position of the ETT is a big problem. Second, sedation after a few hours of high frequency. Third, decrease preload and hypotension. Third, hyperinflation. Fourth, secretion. Fifth, fluctuation of CO2 level. Fourth, high frequency is a labor demanding. You need more nurses. And high frequency oscillator setting will change dramatically with change of pathophysiology. Now we have a new option where we use VG with high frequency. And the VG in high frequency equal to dead space, which is 1 to 3 ml per kg. The importance of VG is prevent fluctuation of CO2 with change in pathophysiology of the diseases. So you don't need to track, and it will reduce the labor demanding of monitoring and changing the setting of high frequency with changing of the pathophysiology. When you select VG, there will be max amplitude, so you'll have two amplitude, not only one amplitude. You have the max amplitude and you have the measured amplitude. The measured is the machine will deliver to achieve the tidal volume, the target VG. And you need to keep your max amplitude about 5 centimeters above the measured amplitude. To wean high frequency with VG, you first need to wean the VG, followed by the maximum amplitude, tracking or following your measured amplitude by 5 centimeters. So if your VG is like 2 ml and you have an amplitude of, let's say, 22 to achieve that, your max should be 27. And when you want your VG to 2.5 and your measured amplitude down to 20, now you have to wean your max to 25, and so on. So you need the max amplitude should follow the measured amplitude by 5 centimeters to achieve the target volume. Always, almost always achieve your delta wave by decreasing your map as well as your amplitude. So here let's illustrate it and make it more simple. So you have here a conventional ventilator, and the conventional ventilator gives you a map. And when you look at the conventional ventilator, the map will change. So you can see it 11, 10, 9, 12, 14. So you need to keep monitor until you select a number which is the average map on conventional. Then you need to increase the map on high frequency by 1 to 2 centimeters above the map on conventional ventilator. Then you select a number which is double the map, and that will be your amplitude. So you select the map 1 to 2 centimeter above the map of the conventional, then you make a number which is double the map to get the amplitude. And then you select the frequency, which is high frequency in a small baby, high frequency in homogeneous disease, low frequency in a term baby, low frequency in non-homogeneous disease. Then you can increase your amplitude by 1 to 2 centimeter at a time if there is no chest rise, until you reach an amplitude that is showing a good chest waggling. If you need the amplitude from here to here, triple the map, and you need to drop your frequency by 1. Then you need to do an X-ray. On the X-ray, you count the ribs. 1, 2, 3, 4, 5, 6, 7, 8, 9. So you need to see them somewhere between 8 to 10. And then you look at the spaces, should be symmetrical. And third, you look at the ribs, should be parallel. And there is no compression of the heart. And look at the cardiothoracic siloe, and it should not be very sharp. And you should not see the diaphragm. You should not see the diaphragm depressed. And you should not see very hazy or very aerated. And that's, you can decide, and you can see, of course, to the level of the ATT, and you can decide the inflation. You can also use the lung ultrasound. So you can divide the lung to a profiles. So you can see a prime profile where you have multiple A lines with sliding, or you can have A profile without sliding, A prime, because of pneumothorax, or you see it A profile where you have multiple A lines but with sliding. Once your inflation has become less, you get more B lines. And if you have pneumothorax, you get B profile. And if you have pneumothorax, you don't see sliding, or you have a pneumonia, or you have a stickiness of the pleura, you will see no sliding, and it's B prime profile. Until you have a pleura which is damaged, you get C profile. And when you see fluid, it's F profile. So you need to see the lung ultrasound between A and B profile. You don't like A prime and B prime because that's been a problem in the pleura, whether it's a pneumothorax or it is a pneumonia and stickiness of the pleura. So you need to see that in conventional and on high frequency. You need to see the lung ultrasound in these two profiles. And on lung ultrasound, you can do scoring when you look at high frequency. So you can see the A lines on one side and B lines on one side. So if you are hyperinflated, you get more A lines. And if you are underinflated, you get more B lines. But you need to make sure that the fluid is okay, because if you have high fluid, you might be overinflated, but you have edema. Or if you have dehydration, you might be underinflated, but you have less A lines because of the dehydration. So you need to make sure that you are not overhydrated and you are not dehydrated. So the number of A lines in comparison to the B lines can tell you whether you have appropriate map or not. The other you can use is do hemodynamic assessment of the both ventricle at short axis lower parasternal view, where you compare right to left and you see the inflation and interventricular septum. You can also look to the superior inferior vena cava, whether it's a depressed or it's open, which mean higher preload and low preload. And on ultrasound, you look to the B lines and A lines. B lines mean underinflation, A lines mean overinflation. You can also use the TAPSE or the tricuspid excursion movement that assess the right ventricle. So a TAPSE of 1.6 means sick right ventricle, and you probably have a problem. But also you can see the inferior vena cava on a mode and assess the inflation. You can also use the ultrasound to assess the change in the size of the diaphragm contracting and not contracting to look at the effectiveness of your ventilation. Then after you've decided that there is a chest movement, that your FiO2 went down 40 and your CO2 is okay, so you are happy with your setting, the frequency, the amplitude, and the map, you need to consider sedation, because you'll have huge fluctuation of oxygen because of the reaction of the baby to the ventilator. If you have a dehydration by lung ultrasound and you get hypotension, you might need to prime your circulation by a normal saline bolus and consider inotroth. The suction, the frequency of suctioning might interfere with the way you ventilate. And ETT position can cause a huge fluctuation of the CO2, especially in positioning of the head, whether it's a midline to the right or to the left. So what are the sedation that I select? I can select some narcotics such as fentanyl or morphine. I might use midazolam, but also I might use adjunct sedation such as dexmedetomidine, which is non-respiratory depressant, and they don't cause hypotension, and it's alpha-2 agonist. And it does not cause hypotension like clonidine, and has no effect on the baby contractility such as the guanfacine. So dexmedetomidine are a good choice as adjunct to minimize the need for narcotics. When you have CO2 fluctuation, you're having either secretion, or you have a sedation problem, or your ETT position is a problem. So when you fluctuate oxygen, you need to consider sedation, or you might have PPHN, or you might have a problem with your ETT position, or your pathophysiology are changing and your tidal volume changing, and in this case the VG can help. So how we select the inspiration to expiration ratio? Now we have two types of oscillating ventilator, either use membrane or piston. So we have the membrane, and the membrane goes in and out by changing the position of the holder. So this is the membrane at the start. So when the holder move in and to one side, bend the membrane, cause active out. When they move to the other side, they cause active in, and therefore they do like that. So that's how to create the ventilation from the baseline. But if you look at the baseline, the airways are equal between the upper and lower. But when you breathe out, the ventilator will suck the air from the upper airway first, and therefore the upper airway collapses because it's active out, leaving the lower airway not collapsing, and that's the reason why it causes air trapping. So when you select 1 to 1, that's what will happen to the airway. You see? So when you do active in, the first part to expand is the upper airway, and therefore look at the airway will change like this when you use 1 to 1. So when you see air trapping by assessing by lung ultrasound or by hemodynamics or by X-ray, and you see this, you might need to change your ratio. So instead, the other way to use the ventilator is piston. But also the piston is active in, active out. So the piston pull instead of changing a holder, and it's moved like this. But it will cause same way change in the upper and lower airway. When you change the rate to 1:1, now you're giving more time for the expire active out, and therefore you will cause less collapse of the upper airway, and therefore you will reduce the trapping. So if you ventilate and you're happy now, you want to start weaning. If you want to wean, you start to wean your mean airway pressure by 1 centimeter at a time. If your CO2 is high, then you need to keep your amplitude the same to increase your delta wave. If your CO2 is normal, then you need to wean the amplitude while you're weaning the map by 1:1 to keep the same delta wave. If your CO2 is low, then you need to wean your amplitude double the weaning of map. And when you wean the map, you need to keep your FI2 less than 30%. If your FI2 need went up to keep the target saturation, then you might need to revert your weaning. When you drop the amplitude, remember that when your CO2 is low, to drop the amplitude by double the weaning of the map. If you reach an amplitude of less than double the map, stop weaning the amplitude. And that time you start to wean your frequency. And remember, when you wean the frequency, you get a bigger tidal volume. So you might push CO2. So once you drop the frequency and your CO2 start low, you need to stop. So how we do the weaning? You look at the CO2 level and the oxygen level. If your CO2 low, then decrease delta wave by decrease the difference between amplitude and map, or increasing frequency. If your CO2 is high, sorry, this is wrong. This one, and this one is wrong. So if your CO2 is high, then you need to increase your delta wave by dropping the frequency. While if it's normal, you try to wean. CO2, again, this is low, this is high, this is the reverse, this is typing error. So if your CO2 is low, you increase your map. If your oxygen is high, you decrease the map. And if it's okay, you try to wean. So this is an example of ultrasound guided map. So you can see a map of 10 gives you some separated B lines with almost no A lines apart from the pleura. When you increase the map to 11 centimeter, you get some A lines and more A lines and more A lines. So you can use the ultrasound actually to guide your map. And you can see here, before the lung recruitment, you have like tissue-like, if people know how to, tissue-like lung with penetration sign, because you can see behind it. And you can see here the penetration sign disappeared and start to see some B lines separated, and you might get A lines. So this is underinflated, good inflation through lung recruitment guided by ultrasound. So you can see here we are increasing the map using the lung ultrasound, and you can see at the end when we reach appropriate map you have multiple A lines. Okay, probably 17 to 18 is the good for this baby because we have A lines versus B lines. Here we have more A lines. So might be 18, 16, or 17 is the best for this baby. Again, you can see more aeration, A profile, less aeration, B profile, and then you can move in between by controlling your map. And again, I'm using same, no B lines, 1 B line, 2 B lines, 3 B lines, 5 B lines, and full white line. So here is better inflation, here is less inflation. And this is a video. You have the map, you have the flow here, which is in and out. So the minute ventilation is high for the alarm, so the machine is alarming. So we need to change all of that, no time. But anyhow, you can see that the flow in and out, and you see the ratio is 1 and 1. And when you change the ratio, make it like 1 to 2, and look at the difference. You see now you've changed because there is no time, and you can see that in become more than the out. Of course, I'm using a test line, not a baby, so I'm not trying on a baby. Yeah? When you go again, 1 and 2, you will change. And here is your map. Here is your delta wave. Here is your maximum amplitude. Here is your peak, and here is your delta wave, and here is your mean blood pressure. And of course, you can add here. Sorry, not mean blood pressure. That's, while I'm taking this is, the meaning is mean airway pressure. You see many things. You want to add, make it 2 parameters and add another parameter here. So you can select, for example, the high frequency, and you can select the tidal volume, high frequency tidal volume. Okay, I don't want to make it very long. So you can see many things, and you can change the view. So if you go to the next view, it will give you the volume too. Okay? And you can see that the volume is not showing here. It can give you also the C dynamics. You can go to more views, and you'll see the loop, and the loop is not working because it's high frequency. So back. And you can add the tidal volume. So if you go ventilator setting, and you go to the additional setting, so you can add high frequency psi if you want, and high frequency tidal volume. So you can see the tidal volume, and you can decide, let's say we are giving 4 mil of tidal volume, and then watch what will happen. You will see here, this is need to be bigger. Okay. So you can even watch the tidal volume here, called high frequency tidal volume. Where is it? Here. So you can see the tidal volume. And you can see the... So still I did not add, I was thinking that I already added the VG, but the VG is not added here. The measured amplitude to achieve the tidal volume, so you can go up a little bit. So I was thinking that the VG is working, but actually is not working. Oh, we didn't add the high frequency. I was watching. What is the tidal volume? We didn't work. So now I'm adding the VG. Now, yes. So now you can see that we have the amplitude and measured amplitude. So, and always when it's low, let's see at 25, I will make it like just 30 above it. So you can see the max amplitude is about 5 centimeters above the measured amplitude to achieve the tidal volume, which is 4. We have the tidal volume, we have the frequency, we have the inspiration, expiration, we have the mean airway pressure, which is 11, the measure, and you have the amplitude, and then we have the delta wave also, you can see, and you can see the effect. Thank you very much. You can turn it up. You have the map. Okay, and I'm done. So anybody has a question? Let me bring it back. So Dr. Arula, if anybody has any question.
Yes, I have number. دكتور ما بعرفش في ايكو مسموتي. Okay, starting with the Dr. Shireen has if there is CO2 retention. I have echo, doctor.
What?
I have echo in my voice.
No, there is no echo. I hear you very well.
Okay, fine. Shireen الأكيد has
يا دكتور.
while oxygen saturation so we will need to amplitude. Do we need to go up by
صوتك يروح يرجع يا رولا. دكتور رولا.
I can speak, doctor.
Yeah, go ahead.
Okay, if we during the use of I feel there is echo, doctor. Yeah, it's not.
Yeah, echo is from you, not from me. So either you are using two computers or you are using I don't know.
At all.
Yeah, so it's from you. The echo is from you.
Okay. If CO2 is high, but the saturation is acceptable. So we will need to increase the amplitude. But
if your CO2 is high and your oxygenation is okay.
Yes.
Okay. So the question is,
we will go up by the amplitude, but no need to increase the map.
No, so if your oxygenation is okay, your MAP is acceptable, you need to wash more CO2, so you need to increase your amplitude. And you should not reach triple, your amplitude should not be triple the size of the MAP. If that happens, then you need to drop your frequency, because once you drop the frequency, you'll have more room for the amplitude to take place and you get better tidal volume. So you have, let's say your MAP is 14, so you can increase your amplitude from 28 to around 36. If you need an amplitude more than 36 for a MAP of 14, then probably you need to drop your frequency. That's how you wash CO2.
I hear doctor saying that we can see if there is any secretions, or we need to escalate sedation, or the baby is not sedated well, so we can sedate him.
So first, when you see secretion, you will see it on the graphs. Second is usually secretion start after a period of time from starting ventilation. Third, you can hear, and when you increase amplitude to wash CO2, I'm assuming that your chest is riding. So if there is secretion and there is a block of your ETT, your chest will not be rising. The waggling will not appear. So if the CO2 is accumulating due to sedation or due to tube position or due to secretions, then you will not see chest rising. But if you see chest rising and the CO2 is still high, then you probably, our amplitude is not good. You need to increase your amplitude.
Okay, doctor.
Any more questions?
Yes, thank you so much.
Most welcome.
Like you make it. I'm just asking the problem with the like less than double, or we make it more than. What is the problem?
Although I did not understand the question, so if your amplitude is less than double,
what will be the problem?
Rula is calling me. دكتورة رولا أنا في السيشن. والله منين أنا ما عندي إيكو. أو خلي أروح في غرفة مكان لحظة بس. So give me 1 minute. Is it still there is echo?
I think, Doctor, the echo from our side, not from your side.
Let's see.
I'm very silent room. So Ahmed, can you repeat your question?
Yes, again. So amplitude below double.
Okay.
Why it is a problem?
It's not a problem. If it's below double, then probably you don't need high frequency. Because it will behave like a CPAP.
What about more than triple?
You will cause hypotension and you will cause lung damage.
This is related to only certain ventilator? Or
No,
it is
it's-
a ventilator?
It is a baseline principle. You might exceed, but you need to be careful if you exceed treble, because you will not have room to achieve your desired amplitude if you are more than 3, and you're probably causing damage. So you know that when the amplitude is so big from the baseline, which is the map, it needs time. So if you needed treble and you needed to achieve that, you need a time. So you need to drop your frequency to give more room for your amplitude to work. Otherwise, you are increasing it, but you are not achieving anything.
I see.
But if
Okay,
your
what about-
amplitude is less than double of MAP, you probably are not doing anything because you're giving just CPAP.
Why
get
I'm
me?
asking because on high frequency VG, maybe the amplitude will drop or up.
So in
Does-
VG is a different story. In VG with a different story, because you will have two amplitude. So you have the amplitude max and you have the measured amplitude. So your amplitude max should not be treble, not the measured. The measured will fluctuate depending on the interaction, because the measured is, you know, that it is a dependent variable, because you know the variables are dependent and independent. In VG, it's a dependent variable, so it depends on the independent variables to achieve, and therefore it's an action between the baby and the machine. So when we say treble, that is not including the VG, because if it's treble, then your VG is not working. There is no way you use your VG and you need a treble amplitude max to achieve VG, because most of time people, for safety margin, they put the amplitude max 5 centimeter above the measured amplitude to achieve your tidal volume or VG.
Okay.
Did I confuse you?
More or less, I understand the principle.
Okay. Any more questions?
Yes. Mr. Nazir is a senior at Cornish Hospital is asking, how about using high frequency as the initial setting? Not
You want
as
to use, you can use it elective.
Yeah.
You can use it elective, definitely.
Not to switch
So-
from conventional to start with
No,
high
you can.
frequency.
So I do have if he want to go and read my Cochrane review about comparison of high frequency and high frequency oscillator versus jet, and it's elective high frequency. Is not a rescue, or is not a failure, or not. It's not an indication. It's just very small baby. So very small babies, your MAB is already known and your frequency is already known. So usually when a baby is very small frequency, I start with MAB of 10, and that's mean, or you can go with 9. So remember the small babies, they can tolerate high. So the maximum PEEP when you start is 15, because after 15 you will get stretching, but you will not get contact between the alveoli and the pulmonary vasculature. So as elective, start for very small baby, and I am assuming it's a very small baby, or for example diaphragmatic hernia and you have like lung hypoplasia, The setting, the map should be somewhere between 8 and 15. And most of the time I start with map of 10, and I start with amplitude of 20 and a frequency a little bit on the higher side. I usually see 11. And once I run, I look to the oxygenation or time I target, and I look to my CO2, and then first I will see chest rising. I might need 22, 21, 23, 24, and so on until I see the chest rising. So yeah, you can start actually elective without need of conventional, but it's usually very small babies or babies those who have lung hypoplasia, and depend on the condition you'll select your parameters. For the map, you depend on the PEEP, and there are many studies what is the appropriate dynamic PEEP. So mostly I start with so I usually start with 9, 11, 12, maybe 8, depend on the situation, depending on the chest movement, depending on the FI2, depend on the thickness of the lung. And frequency usually start 11, 10, or 12, and then I use double the map, and then I go from there as elective without conventional.
Okay, question. That if we what is the parameters to start with? You have answered this.
Yeah, there is a problem. I'm not sure where is the problem coming from, because I can see the sound going up and down, maybe because I selected something. So let me see. Is it better now?
Let us try. No, I have echo.
Oh, strange. I hear you very well. There is no echo for me.
Okay. Another question is asking the ratio 1 to 1, and if we want to everybody is
So when you get 1 to 1, when you have air trapping, so when you see your amplitude is double the map, between double map and triple map, and you have a good chest rise. Okay, and you have good CO2, but you have hyperinflation, whether by lung ultrasound or by X-ray, or you have evidence in hemodynamics that you are hyperinflated, then you need to clear, or the disease is non-homogeneous, meconium aspiration and air trapping is a problem. So you need to clear more airway, and therefore you give more time for expiration to go. The active out will give longer time, and therefore the suction force at the upper airway will be less. Because remember, when the ventilator sucks the air out, the first part will collapse is the closer to the machine, which is the upper airway. And when this upper airway collapse, it will prevent the air from going from the distal airways to the proximal. So what you do is you don't do a fast. So you give more expiratory time, and so the more air will go from distal to the proximal before the upper airway collapse. And that's the reason, that's the indication when you give a higher IE ratio.
Okay. Just a question. Do we need to
do what? Sorry?
Follow the wiggles.
So the chest rising, the vibration of the chest, you need to see it by your eyes. So if you don't see the chest rising, you can put your hand and see and feel the vibration. So you need to see the vibration to know that you are actually not only giving SIPA, because if there is no chest rising, as Ahmed was asking why it's double, and mostly when you are less than double amplitude, you might go sometime less than double, but most of the time when you are less than the amplitude, less than double of map, usually you will not see chest rising. And if your amplitude less than double of the map, you're probably just giving map, you're not giving ventilation. So probably you don't need the high frequency.
This is my question. How often do you depend CO2?
How often you do what?
Depend on that DCO2.
I have no idea. I mean, invasive, non-invasive, that's out of our scope of the talk. So you need to check the CO2 by invasive, non-invasive. It really depends on the situation, on the experience, on the skills, on the calibration, how you trust the machine. There are many factors. But for CO2, I don't depend on the non-invasive. Most of the time, I depend on the blood gas. And also, I depend on the graphics and loops. Okay, so I don't depend much of non-invasive CO2, unless I misunderstand the question.
Okay, and is there any we will consider as
Again, your sound is going up and down.
no, this is the problem. Is there number we can say how high in airway pressure? I should avoid using them.
Wait a minute, let me look at the setting again. Is it really from me? That's
Dr.
happening?
Yahya,
Yes, sir.
just try to read the questions yourself and answer yourself. Your voice is clear.
But why background filter? Let's see, background filter.
Everybody is they have the echo. Except you.
What happened today? Audio? Any problem with the audio? Is it better now?
I have noticed that ruler name appeared twice.
Dr. Dynamite in a different room.
Now, do you feel now is better?
Let us check. No, this is echo.
It's not echo. You're going and coming back.
But for us, we get.
The problem is I cannot restart because you have a...
I know it.
Yeah. So can you type the question? Let me type the question. Let me try typing the question. What is the question? Can you type it, Rola?
Yeah. What numbers consider it as high? Try to avoid.
No, type the question. Type a question. Type for me. Type the question if you can, if you don't mind. What's the number? There is no high number. There is no high number. You can go as high as you want, unless you have hyperinflation, you have hypotension, you have compression of the heart, you have. There is no high number. You can go as high as you can, but in jet you can go even 25. But in high frequency, oscillator, I rarely got above like 17 or 18.
And what is the lowest? 5,
The lowest, the lowest higher. The lowest is, I don't know why you get these questions. Like there is nothing. No answer. No answer. What is the lowest? I don't know. The lowest is when you achieve everything. I mean, if you need a map less than 10, you probably don't need a high frequency. I would say that. If you need a map more than 17, then you probably have a problem. You cannot go more than that. But there is no number. There is no, I cannot give you a number, but it's everything. It's everything you have to, the map, the amplitude, the oxygenation, the blood pressure, the monitors, everything should be monitors. But there is no that such numbers that I can tell you a magic number above the low is the lowest and above it is the highest. There is no such numbers. But I would say if you're less than 10, you probably don't need high frequency.
I see.
Is high frequency contraindication for feeding? No, absolutely not. Absolutely not. There is no contraindication to feeding ever, unless you are intestinal obstruction. Even in intestinal obstruction, I can give you the milk and then take it from you to give you the soothing effect. So there is no contraindication of feeding ever. Even if you are dying, then you probably, I prefer dying eating and not hungry than dying and I'm hungry. So there is no contraindication for feeding ever in neonatology.
Can we have a record, Dr. Sandus?
Dr. Sandus.
Can we have a record?
Yeah, you will have the record. Yeah, you will have the record. It's on my YouTube. You just go on YouTube and then you'll find the record. Any more questions? No? Okay, well, if no questions, then I have to leave you guys. You want me to wait more for questions? No questions?
I think very much.
Yeah, thank you very much. What is the lowest frequency? Probably 3. 3 is probably the lowest, but I never reached 3. But the high frequency can work from 180 to 900, so assuming frequency of 3, but I never went below 8. Never seen below 8. Okay. Dr. Escobar is asking, thank you lots for the extraordinary lecture. Have a question, please. Thank you in advance. To wean a newborn from high frequency, what ventilatory modality must we go through in order to do so? Well, you need your CO2 and your oxygenation. So your MAP is your oxygenation and your CO2 is your amplitude. And we've talked the decoupling of oxygen on the MAP and also on the FiO2, and the CO2 is frequency and amplitude. So you need to wean one or either, depending on what are your current situation, and you might need to wean them together. So you might need to oxygenation, but you might have high CO2, normal CO2, and low CO2. And sometimes you might need to wean your CO2, but your oxygenation might be high, might be normal, might be low. So it's a 6 situation and depend on the situation. So if you have high CO2 and low CO2 and high oxygenation, then you need to wean both. So it really depends on which situation and how you wean. But you have to separate the decoupling and then select your weaning. Okay, well, thank you very much, and we'll hope to see you in the next session. Thank you very much. Have a good day. Bye-bye, or good night, depend on your location. Bye-bye.